Today, what a large sham-controlled trial found about intermittent theta burst stimulation for persistent negative symptoms in schizophrenia, and why the result matters for clinical practice. A patient has stable schizophrenia, minimal hallucinations, and years of avolition, flat affect, and social withdrawal. If antipsychotics are not helping those negative symptoms, can iTBS over the left DLPFC move the needle? The answer from the best available evidence may surprise you. To understand this question, we need to be precise about what negative symptoms are and why they are so difficult to treat. Negative symptoms are not the hallucinations and delusions that most people associate with schizophrenia. They are deficits in emotional expression and motivation, flat affect, reduced speech, loss of initiative, inability to feel pleasure, and social withdrawal. They are among the most disabling features of the disorder, and they respond poorly, if at all, to antipsychotic medications. No medication is FDA approved specifically for negative symptoms. That treatment gap is exactly why neuromodulation approaches have been studied. The left dorsolateral prefrontal cortex plays a key role in motivation, reward processing, and executive function, the circuits that negative symptoms disrupt. Intermittent theta burst stimulation, iTBS, is a specific TMS protocol that uses short bursts of high-frequency stimulation to induce long-term potentiation-like changes in the prefrontal cortex. It has FDA clearance for major depressive disorder. The question is whether it can help negative symptoms in schizophrenia. The best evidence comes from a 2026 double-blind, sham-controlled trial published in the Journal of Clinical Psychiatry. Researchers randomized 141 patients with persistent negative symptoms on stable antipsychotic regimens for at least 3 months to either active iTBS or sham stimulation. 71 patients received active treatment. 70 received sham. The protocol was straightforward. 15 sessions over 3 weeks. Each session delivered 720 pulses of intermittent theta burst stimulation to the left DLPFC at 100% of the motor threshold. The iTBS pattern was 2 seconds of stimulation, followed by 8 seconds off the standard intermittent theta burst protocol, first described in 2005. Patients continued their existing antipsychotic regimens, unchanged throughout the study. The primary outcome was the total score on the scale for the assessment of negative symptoms, the SANS, at post-treatment, 3 weeks after randomization. What happened? Both groups improved significantly from their baseline SANS scores, but active iTBS did not outperform sham. There was no statistically significant between-group difference at 3 weeks, and no significant difference persisted at the 6-month follow-up. Let that result settle for a moment. Both groups improved, but the active group did not improve more than the sham group. This pattern within group improvement without between-group advantage is the hallmark of a negative neuromodulation trial. It is not the same as saying the treatment does not work. It means that in this specific trial, with this specific population, and this specific protocol, the active intervention could not be distinguished from placebo. Why might this differ from earlier, more positive studies? Several possibilities. This trial enrolled patients with chronic schizophrenia and long-standing negative symptoms, a group that may be inherently less treatment responsive. Some earlier studies used different stimulation targets, different pulse counts, or different outcome measures, making direct comparison difficult. The SANS, while standard, may be less sensitive to clinically meaningful change than other assessment tools. And the high sham response rate itself is notable. It suggests that expectancy and context play a significant role in how patients experience and report symptom change. On safety, the trial delivered a clear finding. iTBS was well tolerated. Mild headaches and local discomfort at the stimulation site were more common in the active group than the sham group, but no seizures occurred, no serious adverse events were attributed to the intervention, and dropout rates were similar between groups. The safety profile is consistent with what has been established for iTBS in other populations. And what is the clinical takeaway? Left DLPFC iTBS, in this protocol, for this patient population, chronic stable schizophrenia with persistent negative symptoms did not outperform sham. The treatment remains investigational for this indication. Circuit-based mechanistic rationale is not the same as clinical proof of efficacy, and this trial is a reminder of exactly why sham control matters in neuromodulation research. Bigger picture, negative symptoms remain one of the most treatment-resistant challenges in schizophrenia. Neither antipsychotics nor brain stimulation have established robust efficacy for primary negative symptoms. Until larger trials with better patient selection and validated outcome measures replicate the positive signals seen in some earlier studies, iTBS for negative symptoms should be considered experimental and discussed with patients as such. Questions about today's content or topics you'd like to see covered in future episodes? Drop them in the comments below. And if you found this clinically useful, hit subscribe. More psychopharmacology breakdowns are coming. This video is for educational purposes only and is not a substitute for clinical judgment.